It's a real pleasure to be here. My background, as Hilda pointed out, I've been a general practitioner in Cannons Creek, Pora Union Community Health Services for the last 14 years. I was Deputy Medical Director at PHARMAC and now Medical Director of the College of GPs and sit on the National Diabetes Leadership Group. I've got a real interest in diabetes because of the nature of our practice and what we see on a daily basis. Just a couple of comments before I get into it on diabetes and what I want to do with this presentation. I believe diabetes was one of the single biggest medical equity issues we have in this country, without a shadow of a doubt. I think it's the one that often goes under the radar in terms of public perception and political perception, and it is a real issue out there in the front line in the community. So what I want to do is talk a little bit about our journey at Pora Union and what's actually happened there. But to do this, I want to give context. So I want to start big. I want to start global with what's happening. Then move to New Zealand, then move to some of the issues around Capital Coast, and then move into Pora Union and what's actually happened there and what we're actually seeing on the ground at Pora Union. And I suppose some of our response to that. I don't have the answers. Okay, and I've thought long and hard about this because I don't think there are easy answers. There's a collective perception on what we can do or how we can do this, and everyone in this room is responsible for that, as is the communities we work with. So look, I'll we'll go big and we'll come down as we look at what happened. So I'll just start big. So Margaret Chan is the head of WHO in 2016, and she made this statement. The twin epidemics of obesity and diabetes worldwide are a slow-motion disaster. So what we're seeing in New Zealand, and specifically in certain communities, is not isolated to New Zealand. It's a worldwide phenomenon we're starting to see. Obesity, and the International Diabetes Federation, IDF, stated that obesity and diabetes is a major global issue, and it's up there with climate change and terrorism. They felt that they were the three biggest issues the world are actually facing. And if we look at those figures at the bottom, they're quite alarming. 1 in 11 people in the US have diabetes now, 1 in 16 in the UK, and in some Indigenous populations around the world, in particular the Pima Indians in America. Now the Pima Indians are in Arizona. It's a very distinct tribe that has been studied quite a bit. 50% of the adult population now have diabetes or type 2 diabetes. Some of the talk at the International Diabetes Federation a couple of years ago was within 2 to 3 generations, Pima Indians may not exist anymore. That's the scale of the issue that we're faced with. And with the measles epidemic in Auckland, New Zealand at the moment, one of the terms that was being coined at the IDF, which I was at in Vancouver, was diabetes is actually the measles of the 21st century. And that's what we're not really recognising in public health systems. So if you look at some of the stats that have been thrown around at the moment, 592 million by 2035 will have diabetes around the world. 4.9 million, almost 5 million people a year will die from diabetes. 11% of the total world health spend on healthcare will be diabetes related. And that's sort of the figure that's been tossed around at the moment. And if you look at China, I think this is really alarming. In 1980, 1.9% of the population had diabetes. That has now risen to 9.1%. So this is the scale of the issue that we're facing when you consider that there's over 1 billion people who live in China. Now, if we go to the Indigenous population around the world, there's some interesting things that are starting to show up. So Indigenous populations, and this is First Nation Indians in Canada, Pima Indians in the US, Aboriginal in Australia, and Maori and Pacific are put into this. 80% develop type 2 diabetes before the age of 60, whereas non-Indigenous, 60% develop type 2 diabetes greater than the age of 60. Okay, and then you start to see things like end-stage renal failure is less common in those over the age of 60. So there's these linkages that start to happen. Does that make sense? Yeah. I think this is really important things to understand because it's not just type 2 diabetes, it's where in the population it's starting to occur. And what we're seeing in New Zealand is it's happening at a younger, as I'll demonstrate, younger and younger age groups. The other point I'll tap into about the age of diagnosis, it becomes really, really important, I think, in terms of our thinking. That if on average you've got 20 years till complication with type 2 diabetes, if you're 30 and develop type 2 diabetes, you'll be 50 potentially when you have your first major complication. If you're 65, you'll be 85 before your first major complication. There is a profound difference in those two stats, yeah? A profound difference. And there's a lot of debate about whether younger onset, and some of the experts in the room can talk about this, younger onset type 2 diabetes is more aggressive, and is it a different form of diabetes than older onset? I'm not saying that people who get diabetes in older age groups are not just as important, but there is a slightly different dynamic going on with younger onset, and that's reflected in the figures. So let's look at New Zealand. Okay, so these are the figures, and this is from a year ago from Kirsten Capel down in Dunedin. And again, these figures sort of sit. So the total diabetes rate is about 8.4%. We know there's about 250,000 people with diabetes in New Zealand. About 220,000 of that is type 2 diabetes. New Zealand Europeans about 7%. Maori is about 8.8%, 9% of the population, whereas Pacific is about 15.7%. Okay, so yeah, we do have an issue, okay, and we do have an issue in this country. It's a large burden, as everyone in this room is aware, on the health system. And it's said that the basic figure that is touted is about 11% of the total healthcare spend globally, and that's probably the case in New Zealand as well. I'm lucky enough to got the pharmaceutical spend over the last few years because I was at PHARMAC for a while, and you can see that there has been a substantive climb in the cost of diabetes medication per se over the last few years, and that continues to climb as one component of the overall cost of diabetes in this country. So it is a significant impact on health system in New Zealand. This slide I hope you'd all be aware of, and again, when we start to break out the age group at which the point of diagnosis occurs, this being 60 upwards, this being 60 and below, if you look at European in the red, again around the age of 60 it really starts to take off, so it's this older age group. It's also happening younger, but if we look here at Maori in the purple, that's substantively less age that's occurring, and if we look at Pacific here, in the blue, that's a lot younger, that's starting to really occur. So it's this left shift in terms of the point of diagnosis, which I think everyone in this room would be familiar with. And I'll show you figures from Capital Coast and show you figures from our practice, which actually demonstrate this is exactly what's happening in the real world at the front line. So this left shift in terms of the point of diagnosis is really starting to become quite pronounced in New Zealand. Again, the relative risk of developing diabetes, another way of looking at it. This is a table that some of you may be familiar with. This is the age here, and this is European, Maori, Pacific Island, other. And I think it's this group here we need to be really sort of concerned about. These 40 to 70-year-olds, okay? And in particular Pacific, if we just look at Pacific, if you look at this 40 to 59 age group, and you consider European as being 1, then Pacific is 5 times more likely to develop type 2 diabetes. Rising, yeah, sort of sitting around there about 5 to 6 times more likely between that 40 to 60 age group. So again, that's reflected of this left shift and this rate of diabetes developing. Again, I think this is a really alarming stat. It comes from the Ministry of Health. Paul Jury provided this back in 2017. And this is the one to really concentrate on. So this is the diabetes death-related ratio. So if you consider European being 1 with diabetes, this is the ratio for Maori and Pacific. And again, it's in these younger age groups we need to be really concerned. And in particular Pacific, if you're 50 to 54 with type 2 diabetes, you are 7 times more likely to die from that type 2 diabetes than if you're European. Now, look, I think we can get a bit down about this, but I think we need to face the reality of what's actually going on at the moment. Yeah, Maori sits around 6, and it ranges from about 6 at the age of 40 to 42, to 5.8, 60 to 69. And you'll notice as you get older, it sort of starts to come together. Yeah, but it's really this younger age group that should be an absolute concern. Again, down the bottom, but this is Maori versus non-Maori, the difference in terms of life expectancy. So this is people with diabetes. If you're non-Maori, you lose about 5 years of life overall. If you're Maori, it's about close to 9 years of life. So again, there's these equity issues that just pervade diabetes in this country. So chronic kidney disease, I think, is a particular issue that really highlights the issue. So Maori and Pacific progressed to end-stage renal failure, I think for reasons that are not well understood. And this is the point we need to make. And then I think there needs to be a lot more study into this. It's 7 to 13 times the rate of European, which is why, actually, if you look at somewhere like South Auckland, 79% of the patients in dialysis in South Auckland are Maori or Pacific, and 54% of that are diabetes related. New Zealand-wide, there are 3,000 people on dialysis. 54% are now diabetes related, and that is slowly climbing over time. In fact, there's a really interesting stat that 0.1% of the patient population are in renal dialysis units, responsible 1.6% of hospital costs. So it just goes back to this cost equation and the high burden of diabetes on the system. And 70% in South Auckland are Maori and Pacific, as we know. However, there's this really interesting thing, and I'm just going to get into primary care. And some of the evidence coming out of the States suggests that a 1% reduction in HbA1c results in a 7% reduction in microalbuminuria. Now, microalbuminuria is really, really important because that's sort of the first stage often in that progression to end-stage renal failure. Now, where is the biggest impact made on things like microalbuminuria and HbA1c at the point of diagnosis? It's actually in primary care and general practice and community care. Does that make sense? So this is really, really important, I think, to start to understand that the biggest impact in terms of outcome will occur in community care or general practice care in this country. I believe firmly that type 2 diabetes is a general practice, primary care, community care issue. Yeah? And that's where the bulk of the care, engagement, treatment, relationship needs to occur. And that is incredibly important for our Pacific communities to understand. Yeah? Because we can make a difference and we need to understand that it is possible to do it. So, just to summarise all that and bring that together in the New Zealand context, this left shift to younger age groups, Pacific are 4 to 6 times more likely to develop diabetes in that 40 to 60 year age bracket. There's a shorter time to complications sort of the younger you are. That's the other thing that happens. So if your average complication rate is 20 years, the younger you get, it seems to get a little bit shorter with that. You get into your 20s, it seems to be around 14 to 15 years, again for a lot of reasons. Pacific mortality is 4 to 7 times the rate of European mortality in that 40 to 70 age group with type 2 diabetes. Renal is 7 to 13 times more likely to progress to end-stage renal failure. And I think the next generation is a real concern. If there's 20 years to complication is occurring, we need to actually be aware that possibly, if you're over the age of 60, maybe you have a better outcome than if you're under the age of 60. That's not to say that we shouldn't treat people with diabetes over the age of 60 with concern. But we need to start to think, I think, a slightly different approach is perhaps needed. Earlier intervention makes, I think, the biggest point of difference, and which is where community care and general practice really comes into play. And the role of general practice and community-based care is critical if we put that context into play. So context is really, really important. We need to think about these figures. We need to think about what's happening in New Zealand overall in order to sort of guide our thinking into terms of what happens at the front line with general practice, with community-based care.
Shouldn't that be pre-diagnosis? Shouldn't it be pre-diagnosis the biggest difference?
Well, yeah, no, look, I'm not going to go into pre-diabetes because I think that's a whole different area. The point of diagnosis, we know someone's got type 2 diabetes. I think we need to be really, really assertive. And in fact, there's some evidence now that if you can get someone's HbA1c back down into the pre-diabetic range, even once, it makes a profound difference to long-term outcome. So yeah, I agree with you, pre-diabetes is really, really important. However, we can't forget we're overwhelmed with patients who do have diabetes. And again, early intervention at that point of diagnosis is critical. So I think the younger the age of onset with type 2 diabetes, the greater the impact. So this is some data out of Capital Coast, which is basically Wellington, for those of you who don't know. And what we did here, and I just want to make another point about the whole diabetes situation with our communities at the front line in primary care. And what we did here, we took the high needs practice, we call them high needs practices. So that was practices like my practice at Priory Union versus non-high needs practices. They may be practices in the centre of town, Johnsonville, Kelburn, who still have high needs patients but have a lot less number of high needs patients. Does that make sense? So we just started to do a ratio and we collated all the high needs practices, and there's about 8 of them in Wellington versus the non-high needs, and said, well, what was going on in these practices? And there's some very interesting things that start to show up. Firstly, and it's a ratio you need to look at. So this is a ratio of these conditions. We took the number of conditions. So if you've got more than one condition, it may be hypertension, plus you may have diabetes, plus you may have some chronic renal failure, plus you may have some COPD. So we took the number of conditions, said what's happening in the different practices. And we went 1, 2, 3, 4, 5, 6, 7, 8. And actually this 5 to 7, 8 is a really interesting one, that the ratio goes from 2.3 times in the high needs practices to 5 times the number of patients with 7 times the comorbidity conditions in high needs practices versus non-high needs. Now, why this is important? Because our patients with diabetes don't just have diabetes. They have a cluster of conditions going on, and we are faced with that. We often think of diabetes as singular, but it's not. It's in context. There's a cluster of things that are going on. They may be psychological, they may be social, they may be physical, and they're all interconnected. So in order to address the issue, we need to actually address a whole lot of things that are starting to go on. And everyone in the community would be well aware of that issue. But the second thing that shows up with these comorbidities is this. And so what we've done here is these are the high needs practices, these are the non-high needs practices, and we've age banded the comorbidities. And what you start to see happening is the comorbidities are starting to cut in at a lot younger age. Does that make sense? So it's not just the diabetes that's cutting in, it's the other things that start to go with it. So if you come down here 60 to 69, and in fact if you go to the 70 upwards, it tends to load into the non-high needs practices. And that's because a lot of those practices have a lot of older patients. Does that make sense? But in our practices, there's a lot less older patients. Because to be frank, a lot of our patients are dying earlier. And that's the unpleasant, unsavoury issue that sits here in this room. We start to go down to these younger age bands and it starts to go into the high needs area. So by 50, 59, 40, 49, and down here, 30 to 39, you can see a very distinct difference starting to show up. Now I can actually verify this because 10 years ago, 15 years ago at our practice, it was reasonably uncommon to diagnose someone in their 20s with type 2 diabetes. It happens really frequently now. And in fact, our youngest patient is now 17 with type 2 diabetes. We didn't see that 10 years ago. So we're actually seeing at the front line this shift thing that's actually occurring. And it's showing up in the data very, very clearly. If we go to specific conditions, we can see the ratios as well. And again, this won't be news to you, but I think it's important for the funders, for the bureaucrats to actually start to see this. We've gone and taken particular conditions. We've done the same thing, high needs practices versus non-high needs practices. We've just done a ratio. So you look at something here like hepatitis C, 6 times the number of patients with hepatitis C in the high needs practices versus the non-high needs practices. We can go along to a whole lot of things. Alcohol and drug dependency, 2.8 times the rate, almost 3 times the rate of patients with drug and alcohol conditions in the high needs practices versus none. I term this the concentration of complexity, that these patients are concentrated into certain practices for a lot of reasons. However, if we go to diabetes, the rate's about twice the rate, and we sort of know that. and pre-diabetes it's about 2.1. But again, these patients will have a cluster of these other conditions going on at the same time. Does that make sense? So we're seeing this real concentration of high needs patients with high absolute physical, social and psychological needs occurring in these practices. So just a final thing on Counties Manukau, and just this is from Wing who's sitting here, and I think it's really important to understand. I think this is a very important stat as well, and this comes from Counties Manukau. So if we look at patients who are poorly controlled, their HbA1c is up over 74.9, that was the definition in this, and take a cluster of practices in County Manukau. If you take them over a year period and look at 1 year versus next year, 2/3 will remain poorly controlled over the next year, and actually 1/3 will improve. So you've got 2/3 staying the same, 1/3 improving due to the work that has been done. However, the total number remained the same because 1/3 who were well controlled become poorly controlled. Does that make sense? So we've got this continual cycle thing, and for anyone who's dealing with what you begin to understand about people's lives and contextually what's going on, nothing's static. We think of this static, we've got improvement and that continues. What actually happens is people cycle, and it'll be due to whatever's happening in their life. Yeah? I have a patient who comes in to see me and her HbA1c's just gone off through the roof again and the insulin's stopped. And she can talk very eloquently about what's going on. And she'll sit there and say, no, I've stopped my insulin. I stopped for the last 3 to 4 months. And we'll say, oh, well, why? What's happened? And she'll say, well, because my daughter's been in the courts for the last 3 months on methamphetamine charges. And that's actually the most important thing to me at this point. It's not my diabetes. So things keep changing. So nothing's static. And I think for all of us who work in this area, we understand that. But again, I think sometimes in the way we talk about diabetes, we don't talk about these fluctuations that occur. And actually what was really important about that data as well, 95% of the people with poorly controlled diabetes attended primary care in that year. Many maybe not for a diabetes review, they're presenting for other stuff which may be acute, which I think comes to a challenge for us, that chronic comorbidity versus acute care becomes a real tension in these practices, in our practices. We're continually battling people who come in with their cellulitis or their chest infection or their other problem, but they may have diabetes sitting there, but we focus on the acute issue, we don't focus on the diabetes. And that is a real issue for general practice and primary care. And this comes down to the opportunistic care that's required versus the planned care. And I'll talk a little bit about, as I talk about pyroreunion as we get into that. And again, this is the other aspect of this I think we need to be really cognizant of. So let's talk about pyroreunion, because everything I've talked about is actually reflected in what's happening in our practice, okay? So let's take it into the front line and look at the response to this that we've tried to do at pyroreunion. But we can look at the data, you see. We've got about 6,300 patients. Cannons Creek is a very small area. It's about 2 kilometres wide. It's a very high deprivation area. I think it's got one of the lowest per capita incomes in the country. It's urban-based. We're about 23 kilometres from the base hospital. A lot of our patients do not access secondary care. That's the other thing I need to say. We have real issues with that. So 60% of our patient population is Pacific, 22% is Maori. The majority of the rest are refugee, mainly from Colombia and Syria and the Middle East. Less than 10% are European. 90% of our patient base is considered high needs or high deprivation. Okay, so we're a very concentrated practice. We have about 420 patients who've been diagnosed with type 2 diabetes. We have about 540 patients with pre-diabetes. Actually, over 15 years of age, about 20-25% of our patients have glycemic issues. And this is really important. Going to pre-diabetes, what we do know about pre-diabetes, once you start to develop pre-diabetes, your risk of cardiovascular disease starts to climb quite significantly. So before you get to the diabetes diagnosis, your cardiovascular risk has started to climb. So there's a whole lot of associated things that have started to happen prior to the diabetes diagnosis. So pre-diabetes starts to become quite important as well. When we look at the age breakout, it totally reflects what we saw in those figures previously with the left shift and the differentials that are going on. So actually, if we look 20 to 29, this is pre-diabetes, this is diabetes. 30 to 34, pre-diabetes, diabetes. 40 to 49, it starts to jump quite significantly. 50 to 59, it jumps. And actually, by the time we get to 60 and over 70, it starts to fall again. And the reason it's falling is because a lot of our patients die very early. Okay, and we tend to be peaking around this area here. So this younger onset is a real issue for the practice, and it's one we've started to acknowledge and realise, because actually this group down here is often really difficult to engage because people are getting on with their lives and their struggles to feed their family and employment and jobs and all the rest of it. And actually diabetes is the last thing on their list, because for a lot of them, diabetes isn't actually affecting them at that point. It's something that's down the track. Or there's a fear of diabetes. There's a fear of what goes on because so many of us are familiar. I had my first patient come in a few weeks ago, or a few months ago now, who sat there and just burst into tears. She's diabetic, controls really poor, mid-30s, and stopped all the insulin again and just burst into tears and was sitting there talking, and I suddenly realised why she'd burst into tears. She basically said, and she's got 2 young kids, lives in one of the worst streets in Cannons Creek, to be honest, next to a tinny house, struggling with the 2 kids, struggling with the diabetes, but suddenly said, I've got no one left. Her whole family had actually died from diabetes. Her dad from congestive cardiac failure at 65, her mum at 61 from renal failure, her brother at 42 from renal failure. And this is a very nuclear, actually, family. She didn't have any other people in the network. And she said that no one else is here anymore. It's just me and the 2 kids. And this is the type of thing we're starting to see. And I think it's really, really alarming. I think you don't know what to say about that or how we actually approach that. So this is the HbA1cs. So this is the other thing that becomes really, really important to understand. So the dark blue is 20 to 40 years. The light blue, the 2 I want you to focus on, is over 60. Now the light blue, most of our over 60s are less than 50 millimoles, or this 50 to 60 millimoles. They're all sitting around here. But if we look at the dark blues, which are the less than 60s, it actually goes the other way. So the HbA1cs are actually really poorly controlled in this younger age group. Yet this is the group that's going to get affected by the renal failure, by the congestive cardiac failure, by the heart attacks. And yet this is the group that's really, really struggling with their diabetes control. And actually just going back to Wing, and this is from Counties Manukau, and this is data from this area that Wing's provided, exactly the same thing is seen. So these are the lower age groups going to the higher age groups. These are the HbA1cs defined as greater than 75, poor control. Maori and Pacific up here, European still, but actually this real differential in this lower age groups with poor HbA1c control. And that's exactly what we're seeing in our practice. So one of the points I want to make is that you need to understand your practice. You need to understand the data within your practice to understand what's happening, because that is the only way you can start to direct service. If we're oblivious to this and we just say it's diabetes, nothing happens. Yeah? Nothing happens. We consider it all the same. It's all sort of this stuff. And we don't see that as differential starting to occur. So here's a patient of mine who agreed to me showing this and showed the level of the problem. And again, this just takes it to the front line because we deal with individual patients under today. So this is Tusi. He's now 42. Diagnosed in 2005 at the age of 24 with type 2 diabetes. So this is very typical. At the point of diagnosis, his BMI was 50 plus. His HbA1c was about 87, so quite high. He had microalbuminuria at the date of diagnosis, a lipid, a cholesterol of 6, this is the age of 25 by the way, and a BP of 110 over 60. Now his family history was interesting because his mother had very poorly controlled diabetes with complications. His grandmother was on dialysis. So again, the family has been just affected with the whole diabetes situation. And he had, well, we say poor adherence, we say compliance, but he was really resistant to progression to insulin. That's where we got to. And actually the reason he was because he was just so fearful of the whole insulin thing, because he saw his grandmother, he saw his mother, and he saw what was happening. And we'd talk about this at length. It wasn't like he didn't acknowledge this, because he did. and he could talk about it, and he was very, very eloquent about talking about it. So over time, there's particular practice influence. Now I'm getting to the practice now. See, the problem is the stress this puts on the practice. So significant practice resource, tending to present acutely with either cellulitis in his leg was the thing he kept presenting with. We had letters, we had texts, we had nurse, we had our community worker go out and visit in the home. We had diabetes case conference, a whole lot of stuff and resource going into to his situation. And in 2014, his HbA1c was 110. And so it wasn't for wanting trying, and he sort of understood this. This is the other thing. And all our nurses and community workers are Pacific, and they could go out and have long conversations, try and engage. He actually lost his job around 2014 due to recurrent cellulitis. So this is at the age of 32, 33, 34. He can't work anymore because of what's happening. And he actually started on insulin at this point. And this was a really big breakthrough. This was great. And he's done really well with his insulin. His HbA1c dropped from 110 to 65. But it's due to crisis. You know, this is probably the thing about it. It's due to crisis that this occurred. Unfortunately, at this point, his creatinine is now 388, his EGFR is 10, and he's about to go on dialysis. And if you consider that the average lifespan on dialysis is 3 to 5 years, this is what we're faced with. And I'm sure this is familiar to everyone in the room. And so what as a system can we do that's better here to actually sort of get us through this as a group? Because there's no single answer to the complexity of these issues that we're faced with. So what was our issue with diabetes management at Paura Union Community Health Service? Well, I'll tell you. Sense of isolation. Middle of Cannons Creek, very little contact with secondary services. And I was scathing to that because that is an equity issue. I don't see why our patients in Cannons Creek cannot get adequate access to secondary services. Because our patients don't go to outpatients. We had a huge DNA rate, and yet we had this total disjointed thing going on. So the increasing demand was becoming overwhelming. There was no standardisation in how we were approaching it. The specialist input was inequitable. I think outpatients' appointments in hospitals is a failed system. It needs to go. It was developed 80 to 100 years ago. It's still there. Why are we stuck with this? I totally agree we need it for some people. I totally agree we need it for some services. But the fact that, there's some specialists in the room, specialists bed themselves in hospital and say that's the only place we'll do this work is absolutely inequitable in terms of our system, and it needs to change. There was a single source of expertise within the practice. We had a diabetes nurse who'd come in. She was quite good. She was great. But what happened was we dumped all the diabetes work over to her. So she did it all. And that was great for the GPs and the other nurses. They thought, this is fantastic. The problem arose when she left. Disaster. We absolutely fell into a hole. Our work was predominantly opportunistic. We weren't getting ahead of the game. There was absolute inconsistency, and the morale was going down the tubes. It was extraordinary. We'd sit there and whinge about how difficult it was all becoming. So something had to happen with this. Something had to happen with what was going on. So we actually started to talk to the staff about what was actually happening, and we've got these things. This was a recent one, but we started this process a few years ago. So we started to have a fast get-together, and we just have hooey about what was going on and what do we need to do and how do we feel about this and what do we need to change. And out of that, you know, there's some things that start to think. There was some things that one of the nurses started to put this together. The barriers to patients. There were changes and disruptions in routine. Staying motivated was really difficult for patients. They were finding it hard to stay positive. There was often feelings of hopelessness, depression, anxiety. They wanted to switch off and forget. In your 20s, you didn't want to think about it. Your 30s, you don't want to think about it. They didn't want to engage in our service. The cost was an issue. Time management was an issue. Health literacy was an issue. Comorbidities, all these comorbidities, this cluster of things that were going on, it just wasn't one single issue. And actually for us within the clinic, it was time consuming. Everything was time consuming. Literacy and language was an issue. The cultural barriers that were often an issue that were going on within the surgery, and resources within the surgery, we were totally under-resourced with coping with this. So things started to think, and it wasn't just the patients or the people who chose to come to our clinic. It was actually the staff as well were really struggling and going under. And all our nurses are Pacific or Maori. We have 3 Pacific doctors in the surgery now. We've got 7 in total. I'm the only European in the surgery. But we were all struggling with the same thing. So we started to look at co-design workshops. This was a recent initiative because there's a whole lot of things that happened from the point we realised there was an issue. We started this last year, so we decided to actually ask the community directly what they felt about diabetes care, and that was a real eye-opener, quite confronting, but really quite good. So we actually started to bring together, we did 4 focus groups. We asked these 4 questions. What was helpful at the time of diagnosis? We're interested in what happened at the point you got diagnosed. What was not helpful? What were we doing that was actually wrong? What improvements could be made? What barriers are present for engaging and managing diabetes successfully? So we decided to ask them what was going on. We had a focus group. We facilitated multiple languages: Samoan, Tongan, Cook Island, Maori, Tokelauan and English. And people with various duration of diabetes were invited, plus their whānau and Ago and family were asked to come as well. They were really quite successful. We were quite surprised. Yeah, people really wanted to talk about it. So yeah, we ran this. Jeremy Krebs, who you might know, who's an endocrinologist down in Dunedin, he came and talked. So our community worker. We had quite a big turnout to these things, and we started to talk about what was going on. The main issues that sort of emerged were these. Education actually came out as number 1. That the actual community wanted more education on diabetes. It was quite interesting. They wanted to know more about it to get that sense of ownership. Language was obviously an issue, which it always is, where you've got English as a second language, and what was going on. Cultural beliefs rated quite highly in terms of my belief, my culture, what's happening. Medication, understanding medication rated highly. Diagnosis support, personal feelings, and actually medical jargon didn't rate as highly as I thought it would. So perhaps we were doing a reasonable job there in terms of some of the terminologies and what we were using. So these were some of the comments that came back, and some of them were quite incisive. So there were things like this: find it hard to find healthy food. Pies are cheap, $1, and readily available when hungry at lunchtime. So this is the reality, isn't it? You buy a loaf of bread in Cannons Creek for 90 cents, really cheap budget, white bread, but I mean, you've got to feed the family. You know, people want to feed the family, and this is what you're forced to do. Need to have better, hard to admit to not understanding. So again, this came through very strongly. So that's that Pacific thing where patients just sit there and say yes and understand, and then you find out 2 years later that no one's understood anything, and that's really quite confronting. Medical only looking through one lens. The feeling of being judged by the clinical team, that's quite confronting. So these are the things: your sugar is not well controlled, your HbA1c is too high, what are you doing wrong? All that type of stuff, which is just, you know, inherent. It's not conscious often, but it's just there. It's just something we put out there. Look at the family situation. Having a deeper connection with the team is important. Sustenance is food of cheese and is connection. Builds trust and connection with people. Understand me and connect with me. Shared experiences help. Personal stories are more powerful. So there was a range of views and perceptions that came back. We set up a project team. So this is our team. This is our healthcare assistant. That's Demelza. That's our community worker, Tiao. That's Ioana, who's our clinical nurse manager. She's ferocious. She's got diabetes between the teeth. She's just charging, falling out there. I just stand clear of her. Just down the thing. That's Mal, who's our diabetes nurse, who's leading the nursing team. But I'll make some comments about the nursing team in the moment. Latia and Fila aren't there. Nadine, one of our younger doctors, that's me, because I've got an interest in diabetes. So what's been our response? And this is the important bit. So how do you respond to this? And this has been a collation of things over the last 5 years, but we're really starting to push it after the community co-design stuff that we're doing. So firstly, the service. I'll make this comment. I believe that the 6,300 people who choose to come to our service come for a reason, that they actually trust us. They have a relationship with the service. It's really, really interesting that they choose to walk into our service but won't go to the hospital outpatients, yeah? They will actually come and they'll sit and talk, and they'll have a connection with a doctor or a nurse or the community worker, and they're quite happy to sit and come and have a chat and talk about what's going on. I think relationship with a key clinician is critical. I think continuity is number 1. Yeah, and that ability to build trust in the service. If there's no trust, nothing happens. So we've got a principle now that they can connect with anyone with surgery. they will get a level of care. Okay, so what I mean by that, whether it's a GP or nurse, we don't have a specific diabetes nurse, we have a nurse diabetic leader. If they come in with their cellulitis or their chest infection and it's a nurse who's not the diabetes nurse, they will still get a level of care or input around their diabetes because we insist that everyone in the surgery has lifted their game with diabetes. So we don't fall into a situation where if one person leaves, we all fall into a hole. Does that make sense? It's a shared responsibility. So connection is really, really important. And what we're finding is patients are building a trust or relationship with one person in the clinic. It may be a nurse, it may be a GP, we don't care. It may be the community worker, it doesn't matter. It may be the physician assistant or the healthcare assistant. It doesn't matter, as long as they can talk to someone, connect. That's the key thing. We're doing health literacy support and reminders to all staff at our clinical meetings, so we're actually putting out there just reminding about language and what we're doing and how we're doing it. We've developed protocols for diabetes and pre-diabetes. It's the first time we started to really standardise things over the last 5 years. Insulin start, we expect all the nurses to have a basic level of insulin start knowledge, with a couple of the nurses having advanced knowledge, but having the ability to do that, and all nurses are required to have basic information about diabetes education. So if they see anyone in the clinic, they'll be able to give them diabetes education. Specialist has been really interesting because I've had the bit between my teeth about what's happened, putting the disconnect between specialist services and primary care. So we now do specialist case conference. We've got Jeremy to come in once every 2 or 3 months, and we sit as a team, all the doctors, nurse, healthcare assistant. We talk about difficult cases with Jeremy. In a space of an hour, we get through about 8 now. We talk about the patients who don't access secondary care and what we can do. It's great because Jeremy's learnt just as much from us as we've learnt from him. We now run combined GP specialist consultations, so we won't allow the specialist to see the patient in the clinic without a GP being present. So the reason for that is often we'll say to them, look, Jeremy's coming in, and what we found is if it was just a separate clinic, often the patient wouldn't turn up. What I can say to my patients is, look, Jeremy's coming in, you can come in and see me, it's free of charge, we don't care. You can sit, I'll have Jeremy here and we'll just have a conversation. And we get 100% of the patients now turning up for the specialist input because they feel trusted and safe in the environment. Does that make sense? We do the same with the nurses, so we'll often have a specialist nurse plus our nurses run combined clinics. So they'll bring the patient in and they'll talk together. So you get that specialist input through there, because the other principle about this is this: the specialist comes in and out. Okay, so for 99% of the time, we're left to do it, not the specialist. So we need to have that step up across the surgery in terms of what we deliver and how we deliver it. And the GPs do something that's slightly different to the nurses. That's the other thing that started to emerge. We have diabetic nurse partnerships, so we have a specialist nurse attached to the clinic to deal with this. And patient flow, we've worked really hard and we've gone with the healthcare home model. We've diverted out acute to chronic. So we now have space for acute patients, we now have chronic patient space, and if a diabetic patient comes in with an acute problem, we feed them through to the chronic stream. And we try and actually, on the day, get something happening. We've now employed a health improvement practitioner, so we can flow them straight through to someone to start to talk about their diabetes at the point of contact when they contact the surgery. These things are really, really important. Process is incredibly important in terms of how you deliver diabetes. It doesn't happen by itself. You've got to really think hard about the service you're delivering. We had a situation a few years ago where all our service was acute. We'd have 60 people lined up outside the clinic. It was hopeless. None of the chronic stuff was getting done. People were just interacting with the surgery for their acute problems. All the chronic stuff just got left behind. You've got to get the balance right. If you don't, nothing works. So they've got to do the modules, you know, the online modules, the 1, 2, 3. We expect them all to run through that and do that. This is the online, NZSS, it's the online module stuff. So we expect them to do that, but we expect them to all take part in the case conferencing. So that's all the nurses, regardless if they've got an interest in diabetes or not. And we have quite a few diabetes education sessions within the surgery. Yep. We're very nurse-led at the clinic. So there's 2 specific nurse-led clinics: screening for patients early, diabetes annual assessments, referral to diabetes podiatrist, pharmacist, dietitian. We try and connect everything up. Diabetes self-management is a big focus for what we're trying to do now. And the diabetes nurse standards, so these are what we expect our nurses to do, so to go through the modules and do it. And the surgery supports them with doing that as a continuing medical education sort of piece. We expect that to be part of what happens. So there's really three: service, specialist equitable engagement, and nurse-led processes. So there's really three that we've divided up to it. And within that is process within the surgery, how patients are connecting with surgery. So we're developing teaching tools. Again, we've done this co-design stuff, so hopefully we'll do that every year or two. We'll get that going. We've run a few education systems now with real life speakers talking about their journey with diabetes and what happens, so that shared experience, we're moving into that. Health promotion, we've started to get the surgery out into health promotion in the community, both the churches and what's actually happening. And we have a lot of stuff in the waiting room around diabetes and raising the awareness. So this health promotion side of things is actually really important. So what can we do better? That always becomes a question. None of this is an answer to anything. And I think every service is going to be different in terms of what they're faced with. I think it is really challenging. I think we gloss over the difficulty we're faced with here. Yeah, we say, oh, primary care should do more. General practice should do more. Community care should do more. Gee, there's a lot of competing pressures out there in terms of what we deliver and how we deliver it. Just look at what happens with measles in New Zealand at this point and the pressures that's putting on everyone. However, if we don't do it, this is my worry, okay? Practice burden will continue to increase, and we're just going to this vicious circle where it's just getting worse and worse and worse, and we feel disempowered as professionals with the situation. And that rubs off onto our patients. Look, this time to complication, 20 years, there's actually a real urgency here with needing to address this, especially in our younger patients. We can't allow this to go on. And there's this community impact, as I explained with some of those stories, on the quality of life of the individual, the whānau, family, oga, community, as well as the negative economic consequence. I keep talking about the cost of this. This is a huge cost burden to this country that we can't adequately resource and deal with this. This idea of younger onset, I think a patient less than the age of 40 diagnosed with type 2 diabetes, should we take the exact same approach as someone who's 65 or 70 with type 2 diabetes? I don't think so. I think we've got to start to differentiate this a bit. We've got to get very clear on our thinking about what's happening here. I think this is a system challenge, both locally and nationally, both for the national providers such as PHARMAC and the ministry, and the national bodies, as well as the local responses to this. And this is absolutely 110% an equity issue. This is about equitable care to our communities and to our patients, and we need to actually step up and address this.